So your endocrine is definitely big on the test. So the nurse caring for a client following a thyroidectomy. The nurse notes that calcium gluconate is prescribed for the client. The nurse determines this medication has been prescribed. Why? Why would we, first of all, why are we concerned with the thyroidectomy? What is a thyroidectomy? Removal of the thyroid. So why is calcium affected?
Parathyroid.
Parathyroid is typically, some of it's typically removed. So, and are we concerned low calcium or high calcium? Low calcium. So if it's removed, that's why we're going to keep calcium gluconate at the bedside if we need to give it. But we don't say low calcium. Instead, we're going to describe what does low calcium look like. Tetany, muscle twitching, tingling of the arms and hands, so spasms. What else did I miss? So let's see, muscle cramps, twitching, burning, tingling sensation, hands and feet, and possibly irregular heartbeat, arrhythmia. So which one here is it? 4 is correct. So, and again, this after thyroidectomy, you could see the drop in calcium 1 day to 7 days after surgery. What is the normal calcium level?
9 to 11.
About 9 to 10, yeah, 8.5 to 10, 9 to 10. So know your calcium level. So again, thyroidectomy, surgical removal, that's just an FYI slide. This is an FYI slide. So thyroid stimulating hormone. If someone is hypothyroid, would it be up or down? Up. Because what's happening is that if you have hypothyroid, your thyroid's not working, it's going to secrete a lot more thyroid stimulating to release these two which are low because the thyroid gland isn't working well, it's underactive. TSH normal 0.4 to 4.2. So let's see other things here that you'll need to know. So again, another FYI slide. Big thing with the thyroidectomy, position. Semifowlers, watch for respiratory distress. Again, you're talking the throat area. You're going to, again, assess for hypocalcemia, the Chebok sign, Trousseau sign, and give calcium gluconate if needed. With any type of thyroid surgery, the problem could be you could go into a thyroid storm.
I just want to be clear. Did you say you leave the calcium gluconate by the side of the bed?
No, I'm sorry. So you should have it for emergency.
Okay.
I mean, unless you have a locked box in the room. But, so yes, it should be, I'm sorry, available. Nothing is ever left on the bedside. So, the other thing is bleeding is minimal. So if all of a sudden there's a lot of bleeding on the gown, bleeding on the bed, I'm concerned. And the first thing I want to do is check respiratory cardiovascular status. But respiratory, because are they swallowing it? Is there edema that's causing increased bleeding? Because there should not be more than a scant amount of bleeding. So increased bleeding, I'm concerned. So those are the big things, thyroidectomy. The nurse care for a client following removal of a thyroid. Immediately post-op, the nurse should, this is post-op, what position?
Okay.
So we want semifowlers, head in neutral position. A matter of fact, post-op, we even teach them to turn their head with support using their own hands so they don't put a lot of pressure on the incision line. So again, nurse in action would nurse prepared to carry out initially. What's my big concern when I go to an exaggerated is my breathing, circulation, so which one? 3. Yep. So maintain a patent airway. A nurse develops a plan of care for our client. Now I'm on hyperparathyroidism receiving calcitonin. Which of the following outcomes criteria has the highest priority regarding this medication? So, someone with hyperparathyroidism, are they going to have high calcium or low? High. So why am I giving them calcitonin? What does calcitonin do? Decreases the calcium. So someone who with parathyroidism that has high calcium, I'm going to give meds to decrease it. What is the outcome that I'm looking for? I'm looking for normal calcium levels. So again, FYI, parathyroids are where? Behind the thyroid gland. And it secretes the parathyroid hormone. So again, regulates a lot of the calcium, causes hyperparathyroidism right there. Symptoms, soon as I see these symptoms, renal stone, constipation, osteoporosis, pathological fractures, paresthesia, polyuria, I'm already thinking of things that I need to do. So the calcium is up, phosphorus is down. I am management. I want to prevent renal stones. I want to prevent pathological fractures. So I want to move them very carefully. So a lot of the symptoms is going to be the direction I go for caring for them. All right, where did this go? Renal, acidic fluid, and right here. Okay, nurse completed an assessment on an elderly client who is being admitted for diagnostic workup for primary hyperparathyroidism. Which client complaint is characteristic of this disorder? So if we look back, you want to know, here's my symptoms. I'm constipated, not diarrhea. So going back here, oops. What is it?
Polyuria.
Polyuria. So, so elevated serum calcium levels produces osmotic diuresis, causing increased urine. So 2 is correct.
Karen, why is it not diarrhea, not constipation with the hyperparathyroid?
So for if a hypo, we will have diarrhea, but not the hyperparathyroidism.
So is it? I was just trying to kind of put it together because
we were thinking hyperthyroidism at first. That's
Yeah.
why we were like, oh, diarrhea, but it's hyperparathyroidism.
It's hyperparathyroidism.
right. So how does it correlate? Like, I know with hyperthyroidism,
Yeah, because you're going to go into a hypermetabolic
hypermetabolic
state.
right.
Yeah.
But with hyperpara, why is it constipation? It's not.
I would probably guess it could be related to the osmotic diuretic, where you're going to lose a lot of fluid,
Okay.
possibly contributing to constipation. So that's a real going back into pathophysiology. I got to really think about that.
Okay.
But that's probably the one thing that I would say is so much fluid's being removed because of the increased calcium, where the reverse is going to happen in a hypoparathyroidism.
Okay.
So, all right, so hypoparathyroidism. Calcium's down, phosphorus is up. Anyone know what the normal phosphorus is? So that's 3 to 4.5. So you would expect it up higher in a hypothyroidism. All right. An appropriate nursing intervention for a patient with hyperthyroidism is to, again, back into hyper, pad side rails for seizure precaution, increase fluid intake, maintain bed rest to prevent pathological fractures, and monitor the patient for Trousseau phenomenon or Traboc's sign. So we're in hyper. So hyper, we're going to have high calcium. So this is out. That's the low.
Is the seizure precaution?
So a seizure, what's seizure going to be? High or low?
Low.
Low. So that's out. So down to these two things. And now remember, hyperparathyroidism causes renal stones. It also causes pathological fracture. So I look at these and say, oh my God, which one is it? Well, the thing is, I'm going to, how do we prevent stones? We increase fluids. Will I ever do strict bed rest to prevent pathological fractures? No. So I'm going to get rid of C. So those two would be the two that I would come down to and say, oh my God, both of those could be it. But it's the B is better than the C because I'm not going to maintain strict bed rest. All right, a care for a client post-op parathyroidectomy. Which client complaint would indicate a serious life-threatening complication that you're going to require immediate physician notification. It's always going to be Strider. It's always going to be immediate physician. It's an emergency, swelling. They're not going to be able to breathe. You did leukemia? Just a couple questions on leukemia, and then I'm going to leave the rest for the end. Big things on leukemia is infection and bleeding. So a patient has recently been diagnosed with leukemia. Which of the following symptoms would a healthcare professional expect to see given the diagnosis? B. So I'm going to expect to see low white blood cell count, low platelet count. And again, any questions that come out, you had 1020 cancer where you had neutropenia and thrombocytopenia. Almost every single time, whether it's in the NCLEX or the course test, they're going to combine them because they know students get confused between neutropenia and thrombocytopenia. So, yes, the bruising, petechiae, bleeding of the gums, bleeding rectum, vaginal bleeding is all low platelet counts. We need to do prevention, soft toothbrush, electric razor, prevention of contact sports. If I'm gonna do a bone marrow transplant or we're gonna do a biopsy, holding pressure at least 5 minutes to stop bleeding. Low gauge needle if I have to give other medications so they're not bleeding. So you need to make sure you know platelet versus infection. So let's see, because this one is platelets. The nurse analyzes laboratory value of a child with leukemia who's receiving chemotherapy. The nurse notes the platelet count is 20,000. Based on the lab result, which intervention will the nurse document in the plan of care? First of all, normal platelet count, 150,000 to about 450, 400, somewhere between 450,000. So knowing that's low, they're at risk for bleeding. This is what I mean. This is neutropenia, 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 and thrombocytopenia. Happens every single time, and a lot of times students will fall down that road saying, oh yeah, I gotta monitor for signs of infection. That's not what they're asking. They're asking about bleeding. Don't get caught in that trap. So for Neutropenia, low blood cell count. What does an infection look like? So, fever, sore throat, cough, congestion, abnormal lung sounds. So that's what an infection looks like. What are we going to do to prevent some of the neutropenia precaution? Anyone remember?
No fresh fruit.
No fresh fruit, no fresh flowers, stagnant water, no one with an infection coming in to visit them. Isolation, private room. If they leave the room, they wear a mask. If they're home, because a lot of these people are home, if they're going into crowd, we want them to avoid crowds. If they're going to go into a crowd, they're going to wear a mask. So, so knowing the difference. No, that's where I think a lot of the questions are going to come. A lot of the questions are going back to your 1020. So, and as far as your lymphoma, when you look at Hodgkin's and non-Hodgkin's, this is the biggest question. Guarantee it's probably going to be on the test. If you see it on the NCLEX, this is the question. The malignant cell of Hodgkin's lymphoma is Reed-Steinberg cell. Absolutely. So that's the biggest thing. So what I'm going to do Monday night is I'm going to go over head injury. I'll put them on if you want them ahead of time. We're going to go over head injury. I'm going to go over emergency, and I'm going to go over bioterrorism. So I'll go A to Z, get them in for you.
How big is bioterrorism?
Bioterrorism, less than emergency. Emergency, you know, I would say bioterrorism, anthrax, smallpox, and tagging. Somebody has a burn greater than 60-70% of the body, what do we tag them? It's going to be black. Because the principle of bioterrorism disaster, we want to do the greatest good for the greater number of people. So we'll go over all of that Monday.
Yeah.
Have a good weekend.
Thank you.
Forgot it was
Yeah.